All right. Good afternoon, everyone. Thank you so much for joining us. My name is Jeff Bundy. I'm the Executive Director of Branding and Engagement here at WFAE. I hope you can all hear me all right. It's my distinct pleasure to welcome you to the first of what we hope will be many regular opportunities for WFAE supporters to meet with the journalists, producers, and leaders here at your Charlotte NPR news station. Today, we're going to have the pleasure of speaking with the Paul and Holly Freestone reporter on health policy here at WFAE, Dana Miller Ervin. Before we get to Dana, I have some housekeeping matters to get to. We are, as you just heard, recording this session. We'll share it via our social media accounts and email soon after the conclusion of the seminar. So be sure to check it out once we've got that posted. Since it is a webinar, only Dana and I will be on camera, but we still hope that you'll participate in the conversation by sharing any questions that you may have via the Q&A link, which is at the bottom of your screen. We'll do our best to answer as many questions as we possibly can. Don't make any promises, but we'll do our best. A few other things that I want to mention. We've got some events coming up soon that we hope you'll attend as well. This coming Monday at 11 a.m., Jadon Marshall, our Chief Content Officer, our CEO, Joe O'Connor, our Board Chair, Richard Lancaster, myself will be sharing information about our newly established Race and Equity team. And we'll be making a very special announcement with Wells Fargo related to the funding of that team. It's a virtual session, a virtual webinar, just like what we're doing today. We hope you can attend, and we'll drop a link for that into the chat as well. Then on March 8th, the Race and Equity team will be hosting an in-person event titled Equilibrium, a conversation about race and equity in Charlotte at Project 658 in Charlotte. Mike Collins from Charlotte Talks will moderate the conversation with Mayor Lyles and many other guests. It'll be live on air and in person. We hope that you'll be able to attend that as well. Now, without further ado, it is my distinct pleasure again to introduce the Paul and Holly Freestone reporter on health policy here at WFAE. Some details on Dana. She's an amazing journalist. Before joining our team, she was a contributing opinion columnist with the Charlotte Observer, a senior nonpartisan investigator with the U.S. Appropriations Committee, a freelance investigative producer with 60 Minutes and CNBC, a program manager and grant maker with the Corporation for Public Broadcasting, a producer with 60 Minutes, CBS News, and CBS This Morning. And she met our CEO, Joe O'Connor, while they were both working with Ted Koppel on Nightline at ABC News. Dana is a 3-time Emmy Award winner for investigative reporting and research. She's also won a Peabody Award, the Alfred I. DuPont Award, and an RTNDA Award for overall excellence. We are clearly very, very happy to have Dana here with us at WFAE. We're going to introduce her and bring her on camera soon, but before we do, let's give you a little taste of the work that she's done here for WFAE and her Price We Pay series.
Now it's time for our healthcare series, The Price We Pay. We're examining the American healthcare system through the medical, business, and cultural systems that benefit some but costs all of us. Americans spend twice as much on healthcare as people in other wealthy countries, and the gap is increasing.
Lack of competition is a big part of the problem. Charlotte, for example, is dominated by 3 hospital systems.
And so they can charge whatever they want because you as an insurer can't say no.
Another problem? Anderson says insurance companies may not even be motivated to rein in costs for many large company plans because they earn a percentage of the bill.
So they have no incentive as long as they maintain the business of getting the lowest price.
Today, WFAE's Dana Miller Ervin looks at another big driver in those costs, the growing complexity of healthcare administration.
The arms race has to do with optimizing something known as medical coding to increase reimbursement. There are 70,000 codes, and the codes are very specific. For example, V97.33XD says the patient was sucked into a jet engine, while W61.62XD means he was struck by a duck.
And then you have software companies that come in that sell tools that will help providers optimize coding, which is to say extract as much money as possible, avoid as many authorizations as possible. And then you have the same thing go on at the insurance companies in reaction. It's like any war, right? The arms dealers do fine.
everything around me was just kind of spinning, and I just didn't know how to get out of it.
She had a stem cell transplant, then 6 months of chemotherapy, and she had to cash in her life insurance policy, retirement account, and pension. But she was in for a surprise when she went to get her new medication, Revlimid.
I said, okay, well, what's the cost? They said, oh, $11,000. I went, did I hear you right? I said, $11,000. I can't take that. I can't afford that. She said, well, you can put it on a credit card, or I just laughed. I said, I'll have to call you back.
Research shows childhood trauma, including what doctors call adverse childhood experiences or ACEs, have a lifetime impact on health, says Atrium pediatrician Shivani Mehta.
We know that people that have experienced ACEs have a 20-year discrepancy in life expectancy.
And the more trauma kids experience, things like exposure to violence, substance abuse, or mental illness in the home, even divorce, the higher their risk of heart disease, cancer, and liver disease, according to the Centers for Disease Control.
Kids, may come to school or come to church and say, well, last night there was a shooting in the neighborhood, and we were all in the streets and we just saw a body lying in the street. Now they could talk about it as a common incident, but it's had an effect on them.
Hey, it's not letting me share video.
Oh, I'm sorry. And I had myself on mute. We're doing a great job. Again, this is the first one. Thank you for your patience. Again, Dana, the Price We Pay series, it was a 12-part series on American healthcare that you produced here for WFAE. There we go. We should be getting your camera on now. Can you tell us a little bit, why are Americans less healthy than people in other wealthy countries, and why do we spend more money on care?
Sure. So that was the whole purpose of the series, was to dig into that. And I tried to stories and how we dug into that rather than go into that. In fact, that is true. The data from OECD and elsewhere, Organization for Economic Cooperation and Development, and elsewhere, does show that we die earlier. We're more likely to die of things which could have been treated, and we're almost twice as likely to have multiple chronic diseases than people in 10 comparable wealthy countries. And we spend nearly twice as much on care. What I wanted to do for this series was not just to obviously sit there and read people data. I wanted to give people stories. And to give an international perspective for the first story, I wanted to find a healthcare provider who worked in both the United States and one of the other countries to give sort of the data human perspective. I eventually I was fortunate to find a doctor who trained at both Duke and Columbia, and now is a cardiologist at Sweden's Karolinska Institute working on healthcare outcomes. And he told us exactly what the data show. Care when you get it here is not worse. In fact, it can be better because of all our resources. But care is variable, inconsistent, and huge numbers of Americans don't have access. And even those with insurance suffer sometimes because our system is so fragmented that it actually hurts our care. So to get into the sort of other reasons, because there are certainly other reasons outside our healthcare system, I started with some data from the Robert Wood Johnson Foundation, which is just, I thought, extraordinary that you can go from one census tract to another, just a simple walk, and see longevity decline. And so I thought, wouldn't it be interesting to see what happens if you go from Charlotte's Eastover and walked less than a mile to Greer Heights? And it turns out longevity drops 12 years. And when I went and put all this data in a spreadsheet from CDC and census and everything, I found that diseases like cancer and diabetes went up almost 50%. So it was a great way to tell a story about the impact of the social determinants of health. And since Atrium has done a lot of work in that area, I talked to them. Social determinants of health we think of as things like access to food, housing, and transportation. But there's another thing you don't hear about as much, and you heard about it just now in the clip, and that is adverse childhood experiences. I didn't expect to hear about that. I really didn't. But then that Greer Heights pastor that you heard told me about how the impact of shootings in the neighborhood. And it turns out kids who are exposed to violence or other traumatizing events have higher illnesses, rates of illness in later life, including things like dementia, believe it or not.
Yeah, well, it's an incredible amount of research and work that you put into the series. You also get into what's driving the extreme costs of American healthcare. Can you talk to us a little bit about your findings and reporting on that side of the project?
Sure. So, I started with an employer. He's a medium-sized employer. He told me that his insurance premiums went up 300% in 17 years, which affected obviously his business, but also wages. And after an employee had a heart attack and ended up in the hospital and then in rehab, his healthcare bills for the entire company went up 30%. It's so
wow.
I started with hospital bills because a third of healthcare dollars end up there. And what was so interesting to me from Johns Hopkins and RAND data is that the size of the hospital bill is obviously affected by a number of things, but one of the factors is the hospital's dominance in a market. So a hospital can only charge Medicare or Medicaid the approved amount, right? But on average, hospitals charge private payers, those with commercial insurance, 247% of what they charge Medicare. In North Carolina, those with commercial insurance pay 273% of Medicare. And in South Carolina, where hospitals are highly concentrated, they pay 344% of Medicare. Now, this is an interesting area and an area where I want to dig some more. Now, RAND's data indicates that cost shifting, the argument that we all believe in and all hear, is not the biggest factor in setting rates. And this is an area where I'm actually looking for data now, and I've been working on this for about a year to be able to dig into this more.
Yeah, we'll get into a little bit of our conversation into some of the stories that you're following right now that you hope to report on with WFAE. Before we get to that, though, you've done some stories on the pharmaceutical industry and the impact there on our health and on the cost of healthcare. Can you share a little bit about that reporting as well?
Well, so I wanted to do a story about how the patent system was being sort of gamed to be able to drug companies were gaming the patent system to increase prices. And so I looked at some of the highest priced, most heavily patented drugs in the country, and I settled on Revlimid. It's a drug for multiple myeloma, which costs $17,000 a year. It's based on thalidomide, so it's a drug that's been around for quite a while, right? But I called every support group in North Carolina to find somebody who couldn't afford their Revlimid. I couldn't find anyone, and they all told me how they were getting their copays paid through charitable grants. Well, I'm like, this is wild. These guys aren't poor. They're not, I mean, they might be on Medicare, but I mean, by and large, these are people, how are they qualifying for charities and how? So I got curious and I did a little digging and I found out that the charities are largely funded by the drug companies. Why? Because according to internal drug company documents, that the Congress dug up, not me, they show that companies love paying those 20% copays. Why? Because then they get 80% they can get 80% back from Medicare. So they can keep raising the prices that way. Now, here's the fun part. No one is supposed to, I'm sorry, it's not really fun. Okay, sorry. No one is supposed to pay for something that will result in a government payout. It's a kickback, right? But the drug companies that fund these charities, they do that because they can't pay the bills directly, right? So they go through these, they set in fact, possibly even set up the charities. I can't prove that, but then coordinate so closely with them that the Department of Justice ended up suing a bunch of companies and charities.
Wow. Do you have, I mean, this is such a complex series of stories. Do you have a favorite story from your reporting on the price we pay?
Yeah, and you heard a little bit of it in the clips. It really is my favorite. You know, it turns out 25 to 33 cents of every dollar you spend on care goes to pay for administrative expenses. I'm having some audio problems, so that's why I'm stumbling here.
You sound great on our end.
Okay, good. That's way more than any other country. Now, it's really, we pay for the cost of our complexity. I have to tell you, my editor's eyes rolled when I told them I wanted to do a story about administrative costs. But it's a great story because we're spending all this money on billing clerks and lawyers and accountants. Why? Because we have 900 health insurers, almost 6,000 hospitals, and more than 100,000 medical practices, which aren't necessarily affiliated with larger hospitals. And they all need to negotiate separate contracts for payment. So there are thousands of negotiations. It's the Lawyer Full Employment Act. So then we take, no offense to any lawyers, anyhow, then I'm married to one. Then we take our fragmented system and we make it as complicated as possible, as one former healthcare executive told me. How do we do that? Well, insurance companies require, as you heard, that records be translated into codes for reimbursement. Well, it's gotten so complicated. There are now 70,000 codes. So you need specially trained and certified coders. And as you heard in the clip, there's a specific code for if you're bitten by a pig. There's a specific code for if you're struck by a duck and injured. So then the providers want to optimize the coding so that they can get more money, and insurers try to push back, right? And so now there's a whole new industry that sells software to both sides to help them optimize coding. And so as the executive you heard and the clip said, it becomes a little bit of an arms race. And like any war, the arms dealers do just fine.
But that seems like a solvable problem. Yes?
Yeah. Well, so in Germany, which has private insurance companies, not like ours, but individual insurance companies, it's not a single payer country, they worried about the costs, the healthcare costs and the impact on competitiveness. And they said, okay, guys, you're going to have a simplified number of negotiations. You're all going to get in a room and do that. Harvard Health economist David Cutler, who, by the way, also wrote parts of the Affordable Care Act, says the United States could save between $50 and $75 billion a year by doing something like that. It's not amazing that we don't have the law to do it. The Federal Reserve does the same thing with banking. It says, banks, you can't just make up your own rules to transfer money, right? But the government, for some reason, in the United States, doesn't see it as its role to try to simplify some of this complexity.
So much of this series, much of this project is kind of at the macro level, looking at these issues across the country. Can you talk to us about, how healthcare disparities, healthcare pricing, how that is? You kind of touched on this a little bit already, but can you talk more about how these are impacting us here locally in the Charlotte region?
Oh, sure. So, I mean, every story has a local component that I did. I mean, you heard the social determinants of health. We saw that right there in Charlotte when we, fascinating story about the effect of education on health and longevity. We went to Taylorsville, and we interviewed, and although we also managed to interview, I'm so excited about that, the Nobel laureate, Sir Angus Deaton, for that story. But, all of these have real and dire local issues, and so Jeff, so I want to say one other thing though, because so far we've only been talking about the series, The Price We Pay. And of course, I've been doing a lot of other stories as well.
Right. Yes.
And one of the stories that we covered, and that honestly, I don't think anybody else in Carolina has covered, is that we've got this massive experiment going on in North Carolina on social determinants of health that's part of our Medicare Medicaid transformation. The federal government has given the state $650 million for a 5-year pilot project to test whether some Medicaid funds are better spent on social services. And the former head of the CMS, Medicaid, and Medicare, told me Washington is watching what we're doing. Remarkably, it doesn't appear so far that other North Carolina reporters are. So, yeah, we're doing local stories.
Yeah, very interesting. Just as a reminder to everyone who's joining us, as all of the attendees who are joining us, if you have any questions that you'd like to pose to Dana near the end of the session today, please drop those in the Q&A, and we'll do our best to answer as many questions as we can. What are some other areas or series that you're thinking about right now? I mean, you mentioned with The Price We Pay that you've been researching this, and some of the stories that you've already filed for WFAE, you've spent months, a year researching. Subsequently, I imagine you're researching things right now for future reporting. Can you give us a little snapshot of what you're paying attention to now?
Yeah, so reporting, I hope to do, right. Well, one topic is long-term care. And that is, honestly, I was talking to one analyst. It's really outrageous that older Americans are told to spend down to Medicaid, which is a poverty program, in order to get long-term care. This is people who've worked all their lives. They've saved money. They've bought homes. Then they sell their homes. It's their biggest asset. And they find they don't have enough to pay for care without bankrupting their surviving spouse or leaving nothing to their kids. I mean, as this analyst told me, why do we have a system where you have to hide your money or impoverish yourself just to get care? So I'd like to dig into that, but that's obviously more than one story, but I'd like to dig into that. Another big area, and it's the 800-pound gorilla right now, is mental health. Everyone's focusing, of course, on what's been happening during the pandemic. So it's a very timely topic, but I'm finding stories that are just, this has been a worsening problem for quite some time. If you're reading some reporting on this, that involuntary commitments have grown across the country. According to one estimate, I want to say, they've grown by 91% in North Carolina over the past decade. That's pre-pandemic numbers. That does not include
right.
Honestly, an involuntary commitment is because someone's either a danger to themselves or others, right? They're suicidal probably, why is that growing? And I started to do some reporting on that, and I think it could be some fascinating stories. I've also been digging into the problem of mentally ill offenders, and it's a completely unreported story in North Carolina, perhaps because it's a group that few people care about, but it turns out that there are plight effects everywhere in the state, especially and including those who've been involuntarily committed. So I know I'm running slow on time. Can you give me? Okay. So
we're good. Yeah, please.
All right. So I'm going to bend your ear on this one. So offenders, mentally ill offenders can be confined in jails and hospitals for years, actually, if they don't have the capacity to stand trial. Now, they haven't been convicted of anything, right? And both hospital personnel and attorneys tell me our system is cruel and wasteful. Why? Because jails can't handle psychotic people because they can't force medication. So what you've got, they have to isolate them. They have to, right? What else are you going to do? So now you take someone who's paranoid or delusional or whatever, and now they're in isolation, and then they have to wait possibly up to 3 months to get an evaluation of their capacity to stand trial, and then another 6 months to get a hospital bed to have their capacity restored, right? So they're suffering so much that one psychiatrist told me it's basically torture, right? But then the hospital restores them, I think it's an average, if I read somewhere, but don't quote me on this, 270 days. It's a long hospital
Wow.
stay.
Yeah, it's almost a year.
Yeah, so it's a
Mhm.
long stay. Then they go back to jail to await trial, and then they frequently decompensate. They wait, right? And so they're no longer able to
Mhm.
stand trial, and so the
Mhm.
process begins again. It's
Mm.
and I have people who are so angry, like attorneys and psychiatrists telling me about this, because we can't always get them back, because you can't
Yeah.
take if they're going on and off medication. If the longer, I can't necessarily get them back, one person told me. And someone at Broughton told me they have one person they don't think they'll ever get back.
Mhm.
Okay, so why is this happening? Okay, here's the crux of the story. North Carolina cut state psychiatric beds by about half in around 2000 with the idea of deinstitutionalizing people. That was a national trend. But we set aside money for community-based services, and then we use that to balance the budget instead.
Mm.
We also, yeah, okay. We also, transferred indigent care, and we made it into a Medicare-based system with the idea, because the feds pay about 2/3 of Medicaid. But we didn't expand Medicaid, and our Medicaid requirements or eligibility requirements are very restrictive. So, as one UNC expert on mental health law told me, if you're mentally ill and poor in this state, you're basically out of luck.
Yeah.
Today, we still have fewer than 1,000 hospital beds, state hospital beds. Now our only now, so it's still less than 2000 levels, but now we have over 10 million people.
Mhm.
We rank 40th out of 50 in state beds, and 40 out of 50 in the country for beds, and 43rd for people who can't get mental health care because of the cost. And here's why it matters to everyone, not just those people. At least a quarter of those psychiatric beds are taken by those getting their capacity restored. So what does that mean for all the people
Right.
who are now involuntarily committed, waiting in emergency rooms, suicidal, right? It means, as of the most recent data I could find, they're now waiting 8 days in an emergency room to get a bed, right? So the mental health lawyer from UNC told me he regularly gets calls from parents of teenagers who are just desperate and furious. It's an outrage.
Yeah. It's an incredibly complex story, and there's really no one better to try to unwrap this onion than you. As everyone who's on the session right now is hearing, you have a very unique ability to look at these problems, these challenges from multiple angles to determine what is the cause of the issues. And I want to touch on something that you said. These are stories that you hope to cover. You didn't say it, but I'll say it. The reason you hope to cover it is because the funding that we currently have for your position in the healthcare reporting that you do with WFAE expires in April. So we are working right now to raise the money necessary to keep you on this beat, to keep you working here with WFAE. So everyone who's on the session right now, if you would be so inclined, we hope you would consider making a contribution to support Dana's work, to support the healthcare coverage that we provide here at WFAE. My colleague Caitlin dropped the donation link into the chat. That donation link will go directly to a healthcare coverage donation page. So that support will go directly into funding more reporting, like you've heard from Dana. And as you can hear, the stories she's got in the works right now, incredibly important to all of us here in North Carolina and the Charlotte region. So we do hope that you'll consider making a donation of any amount. Now that we've gotten that part out there for all of you to consider, let's consider some of the questions that you've asked. We've got a query here from Jeffrey Barnes asking, have you determined who really does not want improvement in the system? Is it the drug industry, the hospitals, the insurers, the doctors? And then a second question, who can make a difference?
Oh, who could make a difference? Okay, that's, the 60. Yeah, you don't have enough money to pay me to find that. I mean, who can make it? I don't know, but
Well, if the donations come in.
right. So that we interviewed Jonathan Oberlander, who's a brilliant political science professor at UNC. He's who studies the politics of healthcare. And what he said is, the problem is that there are so many people who benefit from our healthcare system. And it's not just the drug companies and the hospitals. And I mean, look, it's a fifth of our economy. So a lot of people are going to have to find another line of work, right? How well is that? I mean, we're talking, and then he said, and I love this, he said, and then there are a lot of people who just love their health insurance the way it is, right? And so they don't want to lose that. But having said that, I will tell you that there's a story I'm just dying to do about the drug lobby. It is, and it's really a subset of the healthcare lobby. If you want to understand why things can't change, you really need to understand that.
Well, that actually leads well into another question we have from Ross asking, can you talk about efforts by the pharma industry to suppress generic drugs? And is there any reason for optimism for expanded generics?
I have not researched the efforts to suppress. Well, yes, I have. So, but I don't know this really well, but I do know that they, for example, they pay generic drug companies not to come into the market when they can. They pay them to delay. So there's a pay for delay thing. You want me to tell you about my drug lobby story?
Of course.
So there's a drug, there's a bunch of them around here, believe it or not, that have local connections, but there's a drug, I don't know if people in the audience have heard about it. It's Aduhelm, excuse me. It's an Alzheimer's drug, and it was approved by the FDA, even though there was no proof that it works clinically, right? So they could see indications that it could work, but there's no proof that it works. And so they approved it. 3 members of the FDA advisory committee resigned immediately, calling it the worst drug approval ever. But because in this country you can charge whatever you want, the makers of the drug, Biogen, immediately priced the drug at $58,000 a year for this unproven drug. So Medicare goes, we're going to go bankrupt, right? So now Medicare has to increase its premiums by $20, maybe $21.60 a month. One of the biggest hikes ever. $21.60 a month is a really big deal for a lot of people, right?
Yeah.
Okay. But and Medicare is pretty clear. Half of this is because of just this one drug. Okay, they get under the drug isn't selling so well and everything. They drop the price down to the bargain basement cost of $26,000 a year. And then evidence starts coming out that, oh, whoops, this drug that we approved, well, it turns out brain bleeds, brain swelling. So Medicare goes, okay, well, now we're just going to pay for it. We're only going to pay for it for people who are in clinical trials, because they want people, I assume, I have not researched this fully. I'm just very excited about it, but they haven't. Okay. Pharma goes crazy. Pharma's like, you're depriving us, you're depriving innovation, and this is what's wrong. The Wall Street Journal editorial page writes a column about death panels, and 70 House members write to Medicare saying, you're doing a terrible thing here. You have to reverse it. Among them, our own Madison Cawthorn, our own Virginia Fox, our own, trying to remember who else. There were four Western North Carolina. Oh, Ted Budd, who's not Western, and then Richard Hudson. So I'm just dying to get an interview with one of them and do that story. I think that's a fascinating story.
Yeah.
And it shows the power of why it's so hard to change things.
So we have another question that just came in asking about social detriments to health. Can you talk a little bit about that, what you've researched there?
Social detriments to health?
Yes.
I don't know.
I'm sorry, determinants. I'm sorry.
Oh, yeah,
I misread.
Oh, yes, social
Determinants.
determinants of health. So that was the story. Well, we did a story early on, before even The Price We Pay. We did a story about, where we could map in Charlotte health outcomes with access to food, housing, and housing. I think maybe it was just food and pharmaceuticals, right? And you could see that large swaths of people who were very unhealthy were a long distance from getting food. So of course, that's, if you can't get access to healthy food, that's a big problem. The story that we just mentioned, I mentioned earlier, where we went from Eastover to Greer Heights, that's also about social determinants. In that case, not just access to easy access to food and affordability of food, right? But also things, as I mentioned, like ACEs, the adverse childhood experiences.
Yeah, I just dropped actually into the chat, kind of related to that question, a resource guide that you and the newsroom put together to help people actually in reducing healthcare costs. So it's literally like, here's the website you go to find a less expensive prescription. Here's the resource you can turn to for help paying for some of these medical bills. So it's another incredible resource that WFAE provided as part of our healthcare coverage. So I think we've reached the end of the Q&A portion. I don't see any additional questions in the chat there. So we'll go ahead and maybe wrap up just a little bit early. I want to thank everyone again for joining us. And to remind you again, we are actively working to raise the funds necessary to bring you some of the stories that Dana mentioned here and to expand our healthcare coverage. I encourage you to support this work with a donation of any amount right now via the link that we shared in the chat. We'll try to drop that into the chat again here before we wrap things up. If you'd like to meet to discuss the possibility of a leadership gift in support of the healthcare programming here at WFAE, you can reach out to me directly. I'll put my email into the chat. It's jbundy@wfae.org. We would love to talk with you to see how we can expand this service and expand this work together. Again, thank you so much for attending. Thank you, Dana, for your time and your incredible reporting. Have a great afternoon, everyone.